What are the unchanged procedures? I always plan for results. I don't care about the procedure. Aesthetics were always important for me, and that will imply also to different direction of implant treatment. Means that surgical reconstruction was very much a goal of treatment or a way to get there. I was always aware of facial changes and aging. As Bert has mentioned very early on, posterior placement were the areas to place and to be challenged. And therefore, that osteotomy has changed. It kept on changing now with the changing of the face. And the most important thing is that in medicine, we accept failures as part of treatment. Some of us have more than others. It seems to me strange that in our field of dentistry, failures are, it only happens to your colleague, not to you. So I will discuss failures. Now let's talk a little bit about facial aging. The fact is that with time, whether you want it or not, we lose about 40 to 50% of bone volume and fat. We lose elasticity. So my question is, where will be the implants at 30 years old, 30 years later? And if you assume that the bone volume that you lose, whether it's orbit or the maxilla or mandible, then those changes will occur inevitably. You cannot control it. Those are physiological changes. But you better take care of it in your planning. So those are physiological changes. Intraorally, for me, the challenge is not the success of the implant, but to reconstruct to the best I can soft tissue and hard tissue so that the patient has the option of getting the results that used to be before trauma or before loss. For that, let me share with you some 15, 20 years of cortical cancellous reconstruction of the maxilla. A severely deficient ridge. In this case, we went for cortical cancellous graft from the iliac crest because we reconstructed facially and lingually and vertically the ridge. The implants are placed. At the time, we only had the external hex. In 1993, about 6 months subsequent to surgical reconstruction and the prosthetic reconstruction, and 12 years later, with very minimal changes around the bone graft. So I agree that bone grafting in 3 dimensions is difficult, but it's interesting that some of those who published about 3-dimensional reconstruction of bone now resecting all the bone. Now I'm saying to you the decision should be the patient's decision. And extraorally and intraorally, the way the patient looks 30 years later. Another posterior maxilla, again, a large volume defect, again, horizontal and vertical. Cortical cancellous graft will be placed as a J graft. It's bent in advance. At the time, we did not have the models. I will show you those models later. The implants are placed as an immediate placement. I would not do that again. The area is covered with an advanced flap, always primary closure. And we have a fixed restoration to prevent any transmucosal loading over the implants. In 1993, 2010, 17 years later. So to those of us who say that success is not achieved in 3-dimensional reconstruction, I don't agree. It is technique sensitive, it is challenging, and it is patient dependent, but it can be done. Reconstruction of the whole maxilla, right and left. Again, J graft bilaterally, veneer graft to reconstruct the convexity of the maxilla, an axial cut showing the positioning of those fixation screws. 6 months later, most fixation screws are completely embedded in bone, and some of the hopeless teeth that were kept just to provide for a fixed provisional restoration are then removed, and we have a result 12 years later or 14 years later with complete establishment of optimal facial dimension and facial proportion and lip support and incisal position, all ceramo metal reconstruction. Now, one thing did not change in the way I approach it. I plan for failure. And what goes through my mind when I think that I'll make a mistake, I guarantee you I'll make a mistake. So I have to do something to prevent it. And just not to make you feel bad, the orthopedic surgeon or the spinal surgeon has very little problem. They go for anterior cervical dissection. 6 months later, the patient has problems, still the same complication, and now they go for posterior fusion of 9 vertebrae. Mistakes are not mistakes. The mistakes, of course, is the lack of planning, but complications occur. Those of you who think, well, these are strange situations of peri-implantitis. Well, that's the fixation screws that we use, very similar in a palm of a hand. The orthopedic has no problem. He can see this radiolucency. He does not try to clean it. He doesn't put any instrument there because those radiolucency will increase. All they do is remove those screws and go for further fixation. Moral of the story, what I learned, when complication will occur to me, I have to deal with it. It's not going to get better. It's an interesting study from the University of Virginia and Wisconsin. That's regarding surgery. The majority of surgeons believe that their rate of complication is lower than the average. How come I'm not surprised? There is no correlation at all between accuracy and the clinician confidence. That is to say, those who are very confident usually make more mistakes. Furthermore, many decisions, once mistakes occur, they're arbitrary and variable and without explanation. What also is interesting is that the surgeon who make a lot of mistakes usually will not ask for help, even if help is available nearby. Something for us to learn.